A warm good morning to one and all. I'd like to welcome everyone to the cadaveric hands-on workshop on head and neck surgery being conducted as part of the second International Health and Research Convention jointly organized by the Department of ENT and Department of Anatomy, MGMCRI, in association with AOI Pondicherry. Please kindly raise for the SBV anthem. I would like to kindly request Professor P. Karthikeyan, the organizing chairman, Professor S. Vijay Sundaram, the organizing secretary, and Emeritus Professor Dr. Gopalakrishnan to kindly occupy their seats on the dais. Now I'd like to request the guest faculty for the day, Dr. C. Rayappa, Senior Consultant, Dr. D. Sri Prakash, Consultant, and Dr. S. Kannan, Consultant, Apollo Cancer Center, Chennai, to occupy their seats on the dais. We will now have a short video presentation.
Organization is not like a change in reality. It is like that evolution of intelligence is possible. Creating a unique challenge for the and to deal with even emerging and re-emerging pathogens. COVID-19 is one such phenomenon that the generation has witnessed among the frequent incidents of MERS, SARS, Ebola, etc. Keeping pace with the rapidly progressing world is taking its own toll to the global net and then common individual. Each has become a clear number for illness. It's scary when those are suffering the same condition that are seen as just possibilities in past. Truly, global challenges are emerging to maintain the social and psychological history in individuals. What we need is collective efforts to deepen our understanding on the changing landscape of healthcare. Strategy is to use
I'd like to welcome the Dean of Faculties, MGMCRI, Dr. Ananda Krishnan, sir. We will now have the theme song. A short message from the Chancellor. A short message from the Vice Chancellor. I would now request Professor S. Vijay Sundaram, the organizing secretary, to give a welcome address.
Very good morning to one and all present here. Cordially invite all delegates across the country who are present here. Without your presence, this program would be a successful one. So my wholehearted welcome to delegates and a special welcome to our resource person, Senior Consultant Dr. Rayappa sir, Dr. Kannan Sri Prakash, consultants Apollo Hospital. In spite of their busy schedule and they agreed our invitation. So a special welcome to sir. And special welcome to senior professors and my dear students. It is definitely going to be a great event for another couple of hours. Exciting, very exciting to see the dissection of the eminent surgeons in India. So I hope all you enjoy this program. So once again, I welcome you all for this prestigious event. Thank you all. Jai Hind.
Thank you, sir. Now we will go ahead with the first academic session for the day, a talk and step-by-step demonstration of parotidectomy by Dr. C. Rayappa, Senior Consultant, Apollo Cancer Center, Chennai. I would like to request Professor P. Karthikeyan, Professor and Head of Department of ENT, MGMCRI, and the Organizing Secretary of IHRC 2023 to kindly chair the session.
Very good morning to one and all present here. The first session will be a step-by-step demonstration of parotid dissection by our dear Dr. Rayappa sir. Is a senior consultant from Apollo, and sir has 36 years of experience in the field of ENT and head and neck surgery. Currently working in the department of ENT, head and neck, skull-based surgery at Apollo Specialty Cancer Hospital, Chennai, India. Sir has graduated from Madras Medical College, Chennai in the year 1982, and he has done his post-graduation from Madras Medical College in the year 1986. And he is qualified to become a fellow of Royal College of Surgeons of Edinburgh in the year 1989. And he has advanced training at Sunderland Hospital, UK. And he trained in lateral skull base from leading centers in Europe and USA, Hugo Fish of Switzerland and Mariasana of Italy. And he trained in transoral robotic surgery at University of Pennsylvania, USA. And he has a work experience of King Faisal Specialty Hospital in Riyadh, Saudi Arabia, in the year 1992 to 1994. And from 1995 onwards, sir is associated with Apollo Specialty Cancer Hospital, Chennai. So now I'll request Rayappa sir to proceed with this step-by-step demonstration of parotidectomy. Over to sir. Thank you all. Once again, I welcome you all for this cadaveric hands-on workshop held at Mahatma Gandhi Medical College under the aegis of Sri Balaji Vidyapith. Thank you. And first, sir will demonstrate that, and we have the 5 cadavers. Already, we have allotted the list also. And once the sir demonstration is over, then you can come to the cadaver and start dissection. So first we listen to him, and then we'll come to the near the body. Thank you.
Yeah, fine, no problem. Sorry? Oh, good morning, everyone. First of all, let me thank the organizers, especially Dr. Karthi, for inviting me to demonstrate this surgical procedure. Paropterectomy is basically it starts from the incision, and when you make the incision, you have to think about one, have good exposure of the parotid gland, and also should be cosmetically acceptable. You should not give scar. So yeah, the closer they can't see. I don't think they can see from there. The incision comes at the preauricular region close to the tragus, and junction of the ala and the facial skin goes back a little bit and then comes down the neck, and so that gives a good exposure of the parotid gland, as well as the gives a good cosmesis when it heals up, especially when just be in front of the ear. If you make the incision, that does not give rise to any scar because it makes the skin full there. So I make an incision usually at the junction of the ear lobe on the face, comes down in front of the ear. This you can make it behind the tragus also if you want to avoid the scar. This is the lower part of the mandible here, this is the angle of the mandible. So I'll make an incision about a finger breadth below. Come towards the postauricular region and joins the incision there. You seen? Yeah. When you raise the skin flap, you have to include the subcutaneous tissue also. How much I can show depending upon the how soft the tissue is. இங்க இருந்து வந்த பின்னாடி நல்லா இருக்கும். ஆமா, behind the ear. இப்படி வந்தா நல்லா இருக்கும்.
இங்க வந்துடலாமா? இங்க இருந்து இங்க இருந்தா
இங்க எனக்கு இன்னும் பக்கத்துல வந்துருங்க. இது தள்ளிங்க முன்னாடி. Okay. This make it closer. பக்கத்துல கொண்டாந்து. இந்த பக்கம். இந்த பக்கத்துல வந்துருங்க இந்த பக்கம். Yeah. Yeah, it's fine. Yeah. So this is an incision I normally make, but I don't think that's enough in a cadaver to expose the tissue. So I'll extend it anteriorly. The same thing can be used if the tumor is lying in the just in the preauricular region, the upper part of the upper part of the parotid. So the incision can be extended this way. That's what I'm using now for especially cadaver, so I can't mobilize the tissues otherwise. Just just pull the ear down. Yeah. Gauze piece work. Guys are able to see clearly or no? This is the parotid tissue. Just raise it until you reach the anterior border of the parotid gland. This is the anterior border of the parotid gland. You tend to see the branches of the facial nerve also here, the white fibers coming here. I don't know whether you can see. What glare is it? Huh? Other one they can't see anything there. Ah, this is better. Yeah. These zoom பண்ணுங்க. These small white fibers, these are the terminal branches of the facial nerve there. So once the exposure is done, so during the incision, raising the flap, you can always try to preserve the posterior branch of the great auricular nerve comes from the behind the sternocleidomastoid muscle comes up and divides into two branches. One goes anteriorly towards the parotid, and the posterior branch goes to the auricle, the ear lobule. So that gives sensation to the lower half of the pinna. If you can preserve it, that is ideal. So the next step would be to first let me expose the parotid gland fully. Scissors. easily. Okay, then see. I'm in the way. Okay. So this is the posterior part of the gland. Okay. Can retract it, please. Cat's paw. So the next step would be to basically you don't look for the facial nerve at the moment. Don't look for it. Just dissect the parotid gland of the sternomastoid, atrophy, the posterior digastric, and the external aortic canal cartilage and the tympanic bone. Don't look for the nerve. Just push away dissect the parotid of all these structures. So already have the sternomastoid here. These brown fibers of this sternomastoid. I think so, because yeah, that's the sternomastoid. So this is sternomastoid muscle here. And then you can find the posterior digastric, go down deeper. Yeah. This is the posterior digastric, those tissues all, yeah, this is the posterior digastric. Then I have to separate the parotid tissue from the external aortic canal cartilage. And the plane between the cartilage and the parotid gland is very smooth. So totally avascular, comes out easily in this region. Yeah. If hand comes in, tell me, no? Okay. No retractor. I think you put a bring this one here, yeah. The sternomastoid is still here. This is sternomastoid. Can you see it here? No. This is sternomastoid still. So I can cut the tissues confidently. Yeah, this is the posterior digastric. Now it's clearly seen. Can you make out? Yes or no? This one. This is the sternomastoid. This is the posterior digastric. Okay, so this is the post-operative diagnostic tympanic bone is here that usually the facial nerve bisects the angle formed by the post-operative diagnostic and this tympanic bone. So this is the area where I'm going to find the facial nerve there. Can I sit somewhere?
Yes, sir.
It's probably the facial nerve here. It's difficult to identify it in this cadaver, so. Get a mosquito. Mosquito on the ground. Curved one. Yeah, it's better. Pull this here, please. Yeah. So once you identify the facial nerve, what you have to do is just slide the forceps along the surface of the nerve, open the jaw and lift it up. So that will open the space between the facial nerve and the soft tissue and the parotid tissue, and then you can dissect it off. I'm not sure it's a facial nerve. Yeah, that's the nerve. Slow down. Can you make out the nerve here? This is the nerve, comes up. Sorry, I divide the soft tissue. So this is the facial nerve, and this is the bifurcation. So I slide along the nerve, lift it up, raise it, and divide these parotid tissue on top of that. So that's the nerve. It's a branch. Then again, work on the lower one. See, when you raise the parotid tissue off the post-tibular digastric and the sternomastoid, it makes it easier to mobilize the gland. Otherwise, if you don't release it here, you will be working in a tight space. You find it extremely hard to lift the soft tissues and divide it, mobilize the gland later. So when you do the way I described it, it's much easier to mobilize the tumor and also to mobilize expose the facial nerve well. One minute, this is the lower division, okay? Okay. So this proceeds. You have to proceed like this. I'll do little more, and then I'll show you the other option. It goes up. Again, the same procedure is continued till the end. Lift it up. Divide the parotid. Only thing is sometimes you get the lots of bleeding from these small, tiny vessels. So you have to cauterize the bipolar with irrigation just to reduce the thermal damage. And also, if there's some oozing around close to the facial nerve, we can use epinephrine just with a cotton ball. Just keep it there for a few minutes. I think that will stop. Production. So this is continued till the anterior border, the parotid gland, and we identify all the branches and come out of it. So some cases, what happens is the tumor is close to the main trunk, and you're not able to dissect the tissues of this area, and the chance of injuring the facial nerve is high. So what you do is just what's called a retrograde dissection, identify the peripheral branch, and then trace it proximally. So I'll just show you the example. Sorry, I can come this side. Sorry. Can you see better? Terilla. Okay, sorry. This is the anterior border of the gland. I hope I can see this fibers. In live surgery, it's easy to find these fibers. Yeah, this is a branch here. Can you see this one? So slide it along. The same principle. What I showed before. Go from here. This is a facial nerve here. Okay. So we go proximally, identify the main trunk, and then come back the normal way. So this is a branch I was just doing there now. So this no fibers. It's a small fiber going there. I hope I can dissect. I think same goes there. Yeah. So the two ways we can do it. So if you're able to identify the trunk and go the antegrade, I think that's the best, easiest way to do it. And if for some reason, the same thing can be used in revision surgeries, especially revision surgery, there will be lots of scar tissue at the level of the trunk of the facial nerve. So ideally can come from retrograde way, identify they will not have touched the peripheral branches. So identify the nerve and then come retrograde manner. So once the gland is removed, then I think that's the end of the procedure. But normally I do is there's lots of dead space there, so they give a ugly depression post-operatively. So I put a fat graft from the thigh or abdomen, free fat graft that takes in well without any complications. So I never had any failures in the free fat graft, and that gives a good facial contour. So that's the thing to do. The one thing you have to think about is other one is the angle of the facial nerve fibers it goes. The stylomuscular foramen is quite deep inside, and it has to come to the ramus of the mandible, which is at a higher level or laterally placed. So it actually from the foramen it ascends up and then comes into out of the parotid gland and branches. So if you here see the facial nerve trunk is here, comes ascends up or comes laterally and then divides into branches. No. Jetla படிச்சுக்கோங்க. I think that's the procedure. If you have any doubts, please ask me. And you can proceed with the dissection because you need lots of time to do the dissection. I don't want to. The principle is the same. So identify the first is detach the parotid gland off the sternomastoid, posterobiliar digastric, tympanic bone, and the cartilaginous canal, and move it away at the angle formed by the posterobiliar digastric and tympanic bone. You will come get the facial nerve trunk. Okay, from there it gets into the parotid gland and then branches. It makes the different branches. So all you have to do is just slide the forceps along the lateral surface of the nerve, open the blade, lift it up. So whole tissue will give space for for you to see the facial nerve. Well, after seeing the facial nerve under complete control, you divide the parotid tissue between the branches. I think that's about it. If you have any questions? Okay. I think they can start the thing. No, if they don't have any questions, they can start with the, yeah.
Hello.
I have not exposed it yet, so I'm not sure I can see it here. So yeah, this one. Scissors. No, that's the sternomastoid fibers. Mosquito. Yeah, I think this is the one. I'm not sure. Hmm?
Hand upscale.
Hand is coming the way. Sorry.
Yeah, right, sir.
If you have any doubt about getting the great auricular nerve, you can trace it, go up to the posterior part of the sternomastoid and then trace it forwards. You can identify the great auricular easily. From there, you can send backwards. Retracting the bottom. Retractor here.
Are you looking for the posterior branch of that greater auricular?
Yeah, that's right, yes.
Okay.
I think this is the great auricular.
Yes, sir.
I think I torn into pieces. So anyway, this will look for it when you raise the flap. And only thing sometimes usually traditionally people make a big curve posteriorly to come backwards like this. But that sometimes devascularizes the skin of that area, and also can end up injuring the posterior branch of the great auricular nerve. Okay. How to proceed with total parodontectomy?
Total parodontectomy.
So once you've done the superficial lobe,
Yes, sir.
so you raise the facial nerve, lift it off without doing any significant traction. The traction itself will cause lots of damage to the facial nerve. So lift it up gently with your forceps, not holding it. Lift it up.
So the traction gives more damage to the nerve, isn't it, sir?
Traction also causes damage. So you have to be gentle in lifting it up.
Yes.
Because some people put the red rubber catheter or even the vessel loop, just lift it up. Well, that causes definitely neuropraxia, will cause more damage. So if you can avoid it, I think that's better. Once you lift this facial nerve and its branches, you can lift it up. So only thing is you have to avoid traction injury to the facial nerve and its branches. So what is holding will be the terminal branch of the external carotid artery will be going through the deep lobe. So you should be prepared to ligate it if necessary. That's all. Nothing else is important there. Yeah, that's the retromandibular vein. That's another landmark. It's the marginal mandibular always goes lateral to the vein there. You have to work between the fibers, for the fibers. It's nice to do in a cadaver, it doesn't bleed. So see it, yeah. So you can easily, if you're able to do it in a cadaver, then live patient is much easier. The nerve is be very stronger. So only thing is you have to avoid the traction injury. I think that's a little more tissue you can take it out. So the principle is the same. The fibers.
Perfect, sir. Perfect. So, thank you very much, sir,
You're most
for
welcome.
the wonderful demonstration, step by step.
Something fell out.
It's okay.
It's okay.
It's chilling now.
இல்ல ஏதோ விழுந்துச்சு கீழே. சரி.
So thank you very much, sir, for a wonderful demonstration of step by step dissection of superficial parotidectomy and then finally the total parotidectomy also. So sir has demonstrated nicely all the landmarks. So for the facial nerve, especially the tracheal pointer, the posterior belly of the digastric, and then finally he traced that posterior branch of the greater auricular nerve also. That's also important thing. So thank you very much, sir. Sir, yesterday also we shared the video. So that is the commitment he has. So today he is going to dissect that the previous day itself. He has made a one video and we all shared that in the group itself. Hope you all witnessed that. And thank you very much, sir, for the wonderful demonstration. And is there any other questions you can ask?
Facial nerve during total parotidectomy, sir. What is the chance of not damaging the facial nerve during total parotidectomy, sir? Not damaging during total parotidectomy. It should. Okay, sir. Okay.
Malignant tumor going through the nerve is going through the tumor, so you don't have to worry about it. So usually it should not happen.
So when suppose adherent to the tumor, then how will you manage?
You know, if it is adherent to the tumor, you try to dissect it off. If you can't, then probably you definitely, if it's a malignant tumor, yes, definitely you have to sacrifice the nerve. And you can put a graft also for the resected portion of the nerve at the same time. For benign lesions, usually do not get adherent to it. So unless otherwise it's revision surgery, yes. Revision surgeries are quite sometimes. Most of the time, people do only the lumpectomy, so that's much easier. There won't be any scarring at the level of the stylomastoid foramen. You can easily do it. But somebody has done a good job, then doing it is difficult because the entire nerve is exposed during the previous procedure. So there's been lots of scarring around the nerve. So that's going to be a difficult process.
So, any other questions?
Will type of facial nerve branching like Katz-Catlano classification cause difficulty in like dissecting without damaging the nerve? If so, which type is difficult to raise the facial nerve?
Sorry?
So types of facial nerve branching and anastomosis, they're like types, no, so like Katz-Catlano. Which type is most difficult to raise the nerve without damaging?
I never thought about that way. See, the thing is, the facial nerve branches are not the same in every case. So each and every patient will be totally different. So you have to look for, you don't anticipate a nerve to go only in one direction. And also in tumors, the nerve will be splayed this way and that way. Unless you are careful, whatever the textbook says, the grading, the direction, that doesn't work. Especially, see, normal anatomy is much easier. But when there is tumor, sometimes the tumor comes from the deep lobe and splays the branches on both sides. So you have to be careful. There's nothing. You have to look for the nerve properly. Follow the nerve. You need lots of patience, and if there's lots of bleeding, then you'll tend to mess up. So you have to make sure there's not much. Give hypertensive anesthesia, use a bipolar under irrigation. The bipolar also, if you're not careful, it can cause thermal damage. So if necessary, if it is difficult to find the nerve, come retrograde way, and then depending upon the tumor. So. Yeah, see, every case you think is a difficult case and do it. So nothing is easy.
Thank you, sir.
As sir told, as long as you follow the nerve and get into the plane and you start dissection, whatever the types of branching, everything will get preserved. Even the intercommunicating branches will get preserved. But as long as you have to follow the plane and the technique which he showed, you have to identify the plane, lift, cut. In that, you'll never damage the nerve at all. The problem will come mainly with the location of the tumor rather than with the types of branching.
Sir, parotid duct is ligated or not, sir? Parotid duct, sir. Is ligated in total parotidectomy or
No.
not, sir?
I don't even look for it. So
No need, sir.
nothing happens. So one of the problems you can have is the phrase syndrome. They especially since I start putting the fat graft in to fill it in, so the phrase syndrome is the incidence has come down because you block the parapillary fibers reaching the sweat glands. That's it. So place some tissue in between. That's also can avoid it.
Sir, after total parodectomy also, we'll keep the free fat just over the facial nerve branches. So we can keep, like for obliterating the dead space, we'll be keeping the free fat just over that space.
Yeah, that's it.
That's it.
There's no special technical. Just fill the gap with the fat. That's it.
Okay, sir. Thank you.
Oh, thank you very much, sir. So for the wonderful demonstration.
Thank you.
The next we'll have that the participant can, they'll according to your table number, you can go and can start the section. So on behalf of AOA Pondicherry and Department of ENT, I thank Professor Rayappa sir for giving the wonderful demonstration of parodectomy. Thank you very much. Round of applause.
You're most welcome. Thank you for making me a professor. Thank you.
Thank you, sir.
I'm not,
Karthik. Professor.
I'm not a professor.
So demonstrated like a professor only, sir. So he had a lot of experience, and sir is everybody knew about him. He's a wonderful skull-based surgeon and head and neck surgeon. So thank you very much, sir, for accepting our invitation and spending time with us, sir. Thank you.
My pleasure.
Right, sir. So on behalf of AOI Pondicherry and Department of ENT, I welcome Dr. Venkatramanan, SLIMS Medical College, Dr. Saravana Kumar from senior practitioner from Kadalur, Pondicherry, and Dr. Priya from Chettinad Medical College, and all the other faculty and delegates for this program.
It was indeed a very informative session on parotidectomy. Thank you, sir. I would like to request Professor P. Karthikeyan to felicitate the speaker with a memento. Thank you, sir. I would like to request Professor Venkatramanan, Professor and HOD of ENT Department, Sri Lakshmi Narayana Medical College, to felicitate the chairperson, Professor P. Karthikeyan, for chairing the session. Thank you, sir.
So according to your list, you can come to the your respective cadaver. Observe also already we have given that. And this section will be here to help you out. For participants, kindly listen to me. So another 1 hour given to you by 11:15. Then the next session will start. So accordingly, you plan yourself and do that, right? And in between, you can go for a tea also. Tea will be in second floor for the participants. From 10:30 to 11:30, 11:15, the tea and snacks will be available in the first and second floor. For the participants, second floor. For the delegates, for resource person, it will be in the first floor. So in between, you can go and have your tea and come. There is no break. So 11:15, the next session will start.
He is available on the first floor for the resource people and second floor for the delegates. Delegates kindly take turns and have your tea break. Thank you. I'd like to remind everyone that tea is available on the first floor for the resource persons and on the second floor for the delegates. Delegates kindly take turns to have your tea break. Thank you. I'd like to welcome Professor Nirmal Kumar, Director of Hospitals and Outreach Services, MGMCRI. Welcome, sir, to the workshop. The next session will begin at 11:15. So if anyone would like to take a break for 10 minutes. Thank you. Request all the delegates to get ready for the next session by 11:15 a.m. In another 10 minutes, we'll be moving on to the next session. So requesting all the delegates to get ready for the next session in 10 minutes. Thank you. I'd like to welcome our Honorable Vice Chancellor, Professor Subhash Chandra Parisha. Welcome, sir, to the conference. I'd also like to welcome the IHRC Organizing Secretary, Mrs. Asha Suresh Babu. Welcome, ma'am. Kindly requesting all the participants to take their seats. We'll be beginning the second session shortly. Requesting the remaining delegates to kindly take your seat. We're about to start the next session. I'd like to request Dr. Sri Prakash, consultant, Apollo Cancer Center, Chennai, for the second session of the day, a step-by-step demonstration on thyroidectomy. I request Professor S. Vijay Sundaram to kindly chair this session.
Thank you. It's a great pleasure and privilege to introduce the speaker, expert surgeon today, Dr. Sri Prakash. He's worked in various hospitals in Bangalore and he is trained especially in minimally invasive transcatheter robotic surgery. And he has a vast experience of 20 years in the field of head and neck surgery. It's a great honor and pleasure, sir. Thank you very much, sir. Now the session is yours, please, sir. Thank you.
Yeah, I can fix it in pocket. Yeah, thanks. That's okay, fine. That's okay. Yeah. Okay, so I would like to thank the organizing committee for this very warm invite. They've been asked to demonstrate on thyroidectomy. Hopefully, we should be able to find most of the important structures here. And I will just brief you about the incision which we routinely do, which is also cosmetically very good. So certain landmarks to mark the incision. First is to get the thyroid notch. The second one be to get the cricoid cartilage. This is the suprasternal notch. So initially there was a time when the incision was given all the way from the tip of the mastoid. It extends down along the suprasternal notch to the tip of the mastoid on the contralateral side. But now, because of cosmesis, we are giving only a horizontal skin crease incision, which is good enough to do the thyroid as well as the neck. So a nice long horizontal skin crease incision is sufficient. For that, the best would be to make the patient, in case the patient, to make them sit up, mark the incision, and then push in the patient. The reason is that in case you place a lower incision, if the patient has got any bulky breast tissue, it will pull the incision towards the sternum, which will cause a very bad keloid. So that's the reason why we make the patient sit up, then mark the incision. So here the landmarks would be the thyroid notch, the cricoid cartilage, the suprasternal notch, and then mark a horizontal crease incision. So with the back of the knife, I'm just marking the incision. Yeah. So only this much the incision will be. With this, you should be able to do complete neck dissection as well as thyroidectomy. Yeah. So we'll get it a little lower down over here. Yeah, this is horizontal incision. So the most important, yeah. And when you incise the tissue, make sure you go straight from the skin, the subdermis, the subcutaneous flap, all the way up to the strap muscle in a single to the platysma. You should be able to see the platysma when you do the incision initially. So here you can actually faintly see the platysma. It's a very nice cadaver. You're able to see the platysma if you can actually appreciate it over here. So once you see the platysma, gently deepen the incision. Here. So what we need to understand is that there is only platysma on the edges of this incision, whereas in the central portion, there is no platysma. The skin is devoid of the platysma. So make sure you don't go beyond the platysma. Otherwise, you might injure the anterior jugular. See, that's the anterior jugular vein. This is a very important landmark for us to raise the flap, especially in the central portion because there is no platysma. Yeah. Can I have Alice? So the incision is complete here. Yeah, thanks. So when you apply the Alice, make sure that you don't hold the skin, only the subcutaneous tissue. One more, did you have? Yeah. So just the subcutaneous tissue like this. And you should ask the assistant to hold it up straight. So next is take a tooth forceps and gently start raising the flap. So when the assistant holds the skin tissue with the Alice and you hold it with the tooth forceps, you'll find a loose areolar tissue over here. That's your plane actually. You should not go past beyond the plane. Gently cut it here. And when you use the knife, generally in the operating theater, we use cautery, but there are a lot of people who use knife and scissors. In case you're using the knife or the cautery, make sure you don't place the knife straight diagonally like this because you'll cut through the vessels. Bevel it and raise the flap. Okay. That's the platysma. So go subplatysmally. In the center, there is no platysma. So you have to identify the anterior jugular vein and raise the flap. So this is the sternocleidomastoid muscle. We should not cut the sternocleidomastoid here. I think I've just cut a little bit, but you should not cut the sternocleidomastoid. You should stay above the sternocleidomastoid muscle here. So go close, hugging the skin. See, you'll have a very nice plane. This is a relatively avascular plane. There'll be small branches from the anterior jugular which enters into the skin, which you can actually cauterize it. Here we'll cut it off here. See, these are the branches. See, that's our plane now. See, this is the platysma. So this is the sternocleidomastoid, which will drop it back. That's the platysma. So you go subplatysmal. Yeah, like this. And make sure your assistant doesn't hold it like this. The reason is that when actually they hold it like that, there's a very high chance you will actually buttonhole the skin here. So they have to hold it vertically up. They should not pull it like this. Yeah, hold it here. Yeah, nice. So this is the subplatysmal flap. Yeah, 1 second. It's okay. Yeah. Here. So the entire loose area tissue should be on the patient. So hold the tissues like this and gently start raising the flap all around. Yes. See. So what you actually can see here is the platysma, the sternocleidomastoid, and the platysma here. Yeah, lift it up, please. So to what level do you raise the flap? You have to raise it just until you get the thyroid notch. So that's the cricoid. I got the thyroid notch. So you don't have to actually go above the thyroid notch. Your skin flap should start just at the level of the thyroid notch. So that's the thyroid notch. So I'm stopping the dissection just at this level. Okay, so this is the upper flap. Similarly, you'll have to raise the lower flap. So again, realign the Alice. So you have to leave the skin, hold the subcutaneous tissue. Yeah, can you do it? Yeah, good. And hold it. Similarly, there is no platysma here. So you go just underneath the skin and gently raise the flap. The lower limit is up to the suprasternal notch. Can you lift it up? Good. So that's the suprasternal notch. So that's your lower limit now. Yeah. Yeah, sure. Yeah, lift it up, please. Yeah, good. That's okay. You can put it on the skin, not a problem. Yeah, that's okay. So traction, counter traction. With one finger, take a gauze, press it. You find that the tissue opens up very well here. Go in this plane. Yeah. So that's the lower limit. Yeah, you're done. You have a stitch or something? Yeah. Meso ties. Yeah. Yeah, that's okay. We'll just take a stitch. Yeah, that should be okay. Come. Yeah, that's okay. That's okay. Fine. Come. Yeah, that's okay. Yeah, come. This is okay. We'll manage it. So I generally take a stitch so that we can, ask the person who is assisting to hold the tissues instead of holding the skin flap. Hold it. Yeah. Yeah, just step on the knot. Yeah, you can step on the knot. Great. Yeah. Yeah, thanks. Yeah, cut it, please. You have one more, Silk? Yeah. Thanks. Thank you. Yeah, step. No. Both together. Yeah, good. Yeah. Yeah, cut it. Okay, great. You have one more straight artery forceps? Yeah. So now we have two ways to approach the thyroid. I'm going to do it on the right side, the patient's right side. Either you can do a lateral approach or a midline approach, but it depends on the size of the tumor. Here we'll do a midline approach. Lateral approach, that's medial to the sternocleidomastoid, is very important approach, basically for very large tumors where the lobe is gone past the sternocleidomastoid. It will be extremely difficult to go in the midline approach. So then we do a lateral approach. But now for demonstration purpose, which is routinely done, we'll do a midline approach. So basically what we do is you identify the midline based on the thyroid notch. So this is the thyroid notch over here. This is the midline. It's a very avascular area, except that you find a couple of small branches of the anterior jugular vein, which you can just cut it off. Scissors. Yeah. Thanks. So in case it's in the theater, you can use a cautery, which is very good. It opens up very beautifully. Otherwise, you can just cut it off like this. See. So you go all the way, you divide these straps in the midline. You should not cut through the straps, but you should identify the midline and divide the straps. See, that's the midline. It's a very avascular area. And you go all the way up to the thyroid notch. Similarly, you open it down, open it, spread it like this, divide it, spread it like this, divide it, spread it like this, divide it. So now the straps are completely divided in the midline. This is the thyroid notch. So that's about your level of dissection. Once you reach this stage, next what we can do is hold the straps. And then you can, because we have decided to do it on the right side, just get into the plane which is medial to the strap. So this is the trachea. You should not open up the trachea or injure the trachea. Stay very close to this fibrous tissue. As you gently open it, the straps will open up completely. So this is the sternohyoid. So we're now from the hyoid bone all the way to the sternum, there's an attachment, that's the sternohyoid. So we're gently cutting we are just dissecting the sternohyoid. So without injuring any structure, straps, slowly you have to cut it. This will be a very avascular area. You find there is absolutely no tissues here, no blood vessels also. This is how you should do it. So you have to give a little bit of traction, whereas the assistant holds the other side, and then get into this plane. Gently skeletonize the sternohyoid. Yeah. So now the trachea is completely exposed. You can find the glimpse of the right side thyroid, whereas the left is still not exposed. The isthmus should be somewhere in this area. So once you get into this plane, you have gauze. Yeah, yeah, perfect. Next, what you do is hold so you have to leave the sternohyoid, get to the sternothyroid. That's the sternothyroid. and gently start dissecting the sternothyroid. Yeah, this is the sternothyroid. So by blunt dissection, finger dissection, you should be able to peel off the sternothyroid completely. You have a Babcock something? Yeah, yeah, perfect. Yeah, very good. So we will hold this tissue with a Babcock preferably, but still it's okay. And gently, yeah, start dissecting. Yeah, can you put a retractor here? You can leave that one. Leave that, doctor. Just put a small retractor. Bang and back. Yeah, perfect. Yeah, can you come this side, doctor? Yeah, hold this. Yeah, beautiful. See, so what I'm actually holding is the sternohyoid. What is retracting is also the sternohyoid. This is the thyroid cartilage. The cricoid cartilage is here. Now, this is the sternothyroid. This muscle is very important landmark for us to identify the superior pedicle. So what the moment you identify the sternothyroid, what we have to do is gently ask the assistant to give a gentle counter traction. Yeah, leave the you can take it off. So they should just give a gentle counter traction, and this entire muscle will be seen now. That's what you can see now. See, this is the sternothyroid. So we'll gently cut the sternothyroid. There are various, school of thoughts which say, some people say we have to retract the sternothyroid, whereas some say we can cut it. But absolutely, there's nothing wrong in cutting a part of the fibers of the sternothyroid, because it gives us easy access to the superior pedicle as well as the external branch of the superior laryngeal nerve. So gently we're cutting few of the fibers. See, now you can see the sternothyroid attachment very nicely over here. That's the sternothyroid. So now, with again gentle traction, see, now we are getting the thyroid. Slowly start dissecting around the capsule of the thyroid. See, now this is the thyroid. Now we have the entire lobe of the thyroid, and this is the sternothyroid muscle. So we'll try and cut this muscle. I routinely cut few fibers of the sternothyroid muscle because it makes it easy to identify the pedicle here. So see, that muscle is cut now. Once this muscle is cut, we can take off the Babcock. Oh, get the retractors, please. Yeah, this retractor. You have a little bigger one, little bigger one. Yeah. Here. See, can you focus it here? See, this is the entire sternothyroid muscle. If you can actually see it now. See, this whole thing is a sternothyroid. See, you're just getting the glimpse of the pedicle. That's a superior pedicle. This is the sternothyroid, the superior pedicle. You're just getting a glimpse of that. So go close to the sternothyroid, cut it. So this is what I said. It is easy if you can cut the sternothyroid. There is no harm, so you can gently cut it off. See, that's nice. See now, can you hold this, doctor? Yeah. You find a white structure here. That's the external branch of the superior laryngeal nerve. This is very important. We have to make sure we identify this nerve every time, like how we identify the brachial laryngeal nerve. The reason is that this is a sensory supply to the larynx. It is very important. And also in certain people who use voice as a profession, it gives good tension to the vocal cords, the vocalis muscle. So this has to be preserved. This is very, very important. And sorry. Yeah, sure. Yeah, just one minute. Do you have a mosquito? Mosquito? Here, you can just pull the nerve, sorry, pull the larynx. You give it to me, I'll mop it. Let's put it in a holder. See, it's very nicely seen here. You have to hold this, doctor. See, that's the nerve. Here, can you see it? That white structure, that's a nerve. You able to focus it? Yeah, you see that? See now, that white structure, this one. This is the external branch of the superior laryngeal nerve. There are three classifications for the external branch of superior laryngeal nerve. That's called the Cernas classification, where you identify the superior pedicle. This is the superior pedicle, and the point where the superior pedicle joins the thyroid gland. From there, if the nerve is about a centimeter up, it's type 1. If it's about 5 millimeter or very close to the pedicle, it's type 2A. If it's on the pedicle, then it's type 2C. Whereas if it goes through the pedicle, it becomes type C. So this is called Cernas classification. So this is very nicely seen. This is mostly type 1. It's about a centimeter above the pedicle. Now we have the thyroid gland completely visualized. That's the thyroid gland. So this is the pedicle, which consists of the superior thyroid artery and the superior thyroid vein. So what we generally do is, once you get the pedicle, push in a small forceps, open it up, go all the way, and then hook it up, open it up. Sorry, yeah, or yeah. So, or you can use a right angle. The right angle is very safe because it pushes off the nerve more medially and isolates the pedicle. Gently focus it, push it up. That's a pedicle. Yeah. Yeah, feed it, please. So you can ask somebody to feed the tie and ligate it. So generally we use clips. Basically, it's easy, but here you have to you can ligate it also. See, put one ligature very close to the gland. Here, like this. This itself, you can use it as a traction. Can you just hold it? No, don't cut it. Just hold it. Yeah, both the ends. Now with a forceps, take an artery forceps and hold it. It gives a nice traction for us. Yeah, perfect. When they do it, when they give traction, open up the pedicle once again. Yeah, can you feed it now? Yeah, can you feed the stitch? You cut it now. You can cut it now. Yeah. You can cut it here. Great. Hold it like that. Again, take it inside. Put the ligature now close to the artery. That is the external carotid artery. Always make sure you leave a small stump. See, like that. You should give some space for us to cut it off easily, and also posteriorly make sure you leave a very small stump. Just in case your ligature slips, you should be able to identify it. Otherwise, it will bleed straight onto the exit point of the carotid artery. So always give a small stump there. Yeah. So now we have ligated. Now you can cut it. Come. Nice. Cut this also. Yeah, cut this also. I'll cut it. I'll cut it. It's okay. Fine. Come. So now we have cut both the sutures. Once it's cut, now you can divide the pedicle. Still make sure you don't cut the superior laryngeal nerve. See. Now the pedicle is divided. Here. That's it. So you go laterally over here. What you find is the carotid artery. See, that's the carotid artery down there. So you should not open up any of the space or venture down. This is basically for us to get the middle thyroid. So open up the space very well, the upper space as well as the lower space. Now we are good enough to take the superior pole completely. Here. So hold it with, you have an Alice? Yeah. So hold the superior pedicle with Alice. Lift it up. That's it. See, now the whole thyroid is moved out from its bed. You can gently now cut it off. See, now you can actually see the pedicle is completely free. The thyroid is moved from the bed. The superior nervous down here. Yeah. Oh, sorry. Yeah, I'll show you. Yeah, hold it. Yeah, can you see it now? See, this is the pedicle, the cut end of the pedicle. This is the pedicle which joins the gland. So that's over here. This we have ligated. That's the pedicle. Exactly here you'll get the carotid artery. So you don't have to go anywhere there. So ligate the pedicle, put it off. Now, once this is out, you can put the force, the Babcock or the Alice at the center of the gland and lift it up. Now you find the gland is moved from the bed. You find loose areolar tissue. Gently by finger dissection, you can just push it off. I think it may be difficult to identify the parathyroid, but I'll just see if you can see it somewhere there. Yeah, see, this is the parathyroid, this tissue. So the parathyroid will be very close. It will be attached to the gland like this. You find a tissue which is being pushed. That's the parathyroid. Yeah, now the parathyroid is gone down. Now what we have to do is, this is a trachea. The next most important step is to identify the recurrent nerve. So basically we use two techniques. The most easiest and commonest to identify the tubercle of Zucker candle. See, what you see over here, that's a tubercle of Zucker candle. You're able to see it? I think in the pocket, you have to move it, I think. தெரியுதுங்களா? I think தெரியல நினைக்கிறேன். நீங்க இப்படி வந்தாலும் தெரியும் நினைக்கிறேங்க. Yeah, perfect. Can you come this way? Possible? It'll be easy actually. Yeah. Yeah. Yeah, nice. Yeah. இதை focus பண்ணிக்கோங்க. Yeah, yeah, beautiful. Yeah, you can see it now. See, this is the tubercle of Zucker candle. This is a very constant landmark to get the nerve. Actually, now you can see it much better also. So the thyroid gland is up. That's the pedicle. You can actually see the artery lumen over here, very nicely seen. The upper pedicle is gone up, which we have ligated. Yeah. So the thyroid is now out of the bed. This is a Zucker candle tubercle. Yeah, can you hold it? Yeah. So now once you get the tubercle of Zucker candle, what we can actually do is try and get the nerve. So this is the area we should ask your assistant to retract it very well, where the tissues open up like this. So this retraction will help us to open the tissue and also identify the nerve. Yeah, hold it here. Now, another important structure which we have to try and see before we get the nerve is the artery. So what you actually see here is the inferior thyroid artery. So This inferior thyroid artery is the one which supplies the inferior parathyroid over here as well as the superior parathyroid. So as per our older teaching, what we say is identify the inferior thyroid artery and ligate it well away from the gland. But we don't do it that way because the blood supply to the parathyroid is completely gone. So what we do is we hold the inferior, we identify the inferior thyroid artery over here. Okay, gently we tease it and open it, and we have to ligate it as close as possible to the gland after identifying the parathyroid. So superior parathyroid is down. Probably the inferior parathyroid is here. Yes. See, that's the inferior parathyroid area. There'll be a small fat tissue along with the inferior parathyroid. Try and drop it down. So that's the inferior artery. Go as close as possible to the gland and ligate the inferior artery. Yeah. So this is the parathyroid where it supplies the parathyroid, and it supplies the parathyroid and exits the parathyroid to get into the gland. That is where you'll have to ligate it and cut it. So I just cut it off there. Yeah. Open, please. Yeah, great. So this is where you have to ligate it. Can you just clean this? Yeah. So you go all the way there and try and ligate it. See, that's the inferior artery. Yeah, can you cut it close to the gland? Oh, this is good. I'll cut it off. Yeah. Now we cut it. See, that's the parathyroid. We cut it very close to the gland. Yeah. See, it drops along with the parathyroid. So now we have more or less all the structures identified. The superior parathyroid is gone. The inferior parathyroid is down. The inferior artery is also ligated and pushed down. This is the tuberculous Zucker candle. Now we have to start identifying the nerve. So once you get to this plane, the Zucker candle tubercle, gently try and open up this plane. See, this is the trachea. So this forms the typical Jones triangle, which they actually say, which is formed by the trachea, the inferior thyroid artery, and the esophagus. That's where you get the nerve. So gently open up. See, you get that's a nerve. See, can you see that? This is the recurrent laryngeal nerve. So this is a very important landmark. The tuberculous Zucker candle, the inferior artery, this trachea, exactly in this area will get the nerve. So once you get the nerve, open it up. And now dissect it out. Yeah. Are you able to appreciate the nerve here? See, that's the recurrent laryngeal nerve. See, that's a nerve. Here, can you see it? Yeah. So that's the recurrent laryngeal nerve. Once you get the recurrent laryngeal nerve, as I said, it goes exactly underneath the tuberculous Zucker candle. Open up the tuberculous Zucker candle over here. The scissors. See, that's a nerve. Can you mop it? You can see the nerve. Slowly you trace it, you get to the entry point of the nerve. So what generally people now they think is that this is recurrent laryngeal nerve is not like other nerve because it is like plexus. Basically, it is not one single branch. You will find 2-3 branches. There are some instances where there is a main recurrent laryngeal nerve. There is one branch to the trachea, which is a tracheal branch, and another which goes to the esophagus. So here there's the esophageal branch. You have to identify and preserve all the 3 branches. Otherwise, you'll still end up with a vocal cord palsy. So make sure you identify the nerve completely before you cut any structure. Yeah, that's the complete nerve. See, actually, this is the esophageal branch. See, which is actually being cut. Actually, see, it was very tethered. So this is the esophageal branch. The main recurrent laryngeal nerve. You can actually see that's a tracheal branch there. See, there's one branch, that's a tracheal branch. You should make sure you preserve everything in this area. So it is like a plexus. That's very important. Once you identify the nerve, there's nothing much. You can go straight to the isthmus over here. Cut the isthmus. See, now the trachea is completely exposed. So go all the way along the pretracheal fascia. Especially when you're doing a hemithyroidectomy, you have to take it along with a part of the isthmus. So gently cut the isthmus all around. See, and completely take off the pretracheal fascia. This is the Berry's ligament. It is a very hard ligament, so you have to do a sharp dissection to cut this. Can you hold it? You can leave this, doctor. Hold this, yeah. So go close to the trachea and gently cut it. This is where you tend to leave behind a little bit of thyroid tissue because it is very close to the nerve. But especially in malignancy, I think you should not leave behind any tissue because there will be uptake in the post-iodine scan. So you should take off these tissues as well without injuring the nerve. Yeah. So hug the trachea. See, this is the one which holds the trachea to the thyroid gland. The moment you cut it, the trachea is free. The nerve falls down. So go all the way. This is all by blunt dissection. You can remove whole thing. See, this thyroid gland has come out. Now, if you actually see this, I'll show you all the structures. Yeah, can you pull the trachea? I'll hold this, doctor. Yeah. So if you actually see that's the nerve, recurrent nerve. It has got a tracheal branch and the esophageal branch. This is the cricothyroid muscle. This is where the nerve enters into your larynx. So you have to be very careful when you dissect it here. Nerve, cricothyroid muscle, larynx, the entire trachea. This is the parathyroid over here. That's the superior parathyroid here. The inferior parathyroid generally falls down along with the artery, so you don't have to go looking for the inferior parathyroid. When you identify the artery at the entry point of the gland and ligate it, the inferior thyroid along with the thyroid ligament falls down. So the inferior thyroid is also preserved. This is the entire length of recurrent laryngeal nerve. If you dig a little deeper, what you see there is a esophagus. Just pull the trachea a little more. Yeah, what you see down there is a esophagus. Now, if you come up, yeah, can you hold this? One second, doctor. Yeah. See, this is the external branch of the superior laryngeal nerve over there. So that's very important. So that's typical how we do hemithyroidectomy. Yeah. Now, any questions? Yeah. You're done, sir.
Identification of middle thyroid.
Middle thyroid vein is not seen in all the patients. Only about 30% of the patients will have middle thyroid. So here I tried to find out, but it was not there actually. Yeah, that's it. Yeah, feel free to ask any questions, anything. Yeah.
this finger dissection, we bring the thyroid outside.
We can actually do a finger dissection. There is a very high chance. There's a very high chance, especially when you're doing a finger dissection. Make sure you identify the superior pedicle ligated. Make sure you identify the middle third ligated. Then only retract the globe with the finger. Until then, never do a blind finger dissection. It will start bleeding. The entire area will become messy. You will not be able to get the nerve easily then. Yeah.
After the superior pedicle is ligated,
Correct. You have to do a finger dissection. Correct. Yeah. That's all. Yeah. No, this zucocandral tubercle is very prominent on the right side of the patient. Okay. And this zucocandral tubercle is seen only about 35 to 40% of the population, not all the population. In case you don't see the zucocandral tubercle, the other two ways to identify the nerve is get the superior parathyroid. About 3 millimeter to the lower end of the superior parathyroid, you will find the nerve entry point. That's one area. The next is to find it through the inferior parathyroid. Identify the inferior artery. I said the triangle, right? So identify the inferior artery, get the carotid, the trachea, just lower down. That's how we found out. Just lower down, you find the superior recurrent engine nerve. Any more questions? Yeah. No, the superior laryngeal triangle is different, actually.
external branch of superior laryngeal nerve.
No, external branch of
Triangle identification, is it necessary like sternolaryngel triangle?
Yeah, see, external branch of superior laryngeal nerve, the best way to identify it is identify the superior pedicle. Okay, there'll be loose areolar tissue, which is actually called as the roving sign. Whenever you find the loose areolar tissue in that plane, if you open it up, immediately you'll get the superior laryngeal nerve. There is, I don't see any triangle, but the best is stay as close as possible to the pedicle. The moment you open it up there, you'll find the superior laryngeal nerve, the external branch of superior laryngeal nerve. Yeah. Yeah.
Sir, are you going to, sir?
Yeah.
Are you going to total theoretical or heavy?
I'll do a total, yeah.
After that, time for them to, sir, you.
No, I'll do the other side also.
Yeah, fine, sir.
Definitely. We'll move the camera that side.
Okay, sir.
Yeah,
Take your own
same.
time.
Yeah. So the same procedure now on this side. Alice. Scissors. So dissect along the sternocleidomastoid muscle. Yeah. This is the same step again, just refreshing what we did the other side. Go very close to the muscle and dissect it out. Yeah. Can have a retractor. Come. Yeah, the smaller one is okay. Good. So ask the assistant to retract well. And now, yeah, hold here, go here. So I'm cutting the sternothyroid now a little bit. So the moment you cut the sternothyroid, you're straight on the pedicle once again. This is what you were asking me, whether we can do a finger dissection. The problem is, if you do a finger dissection, in case there is a middle thyroid vein, you'll snap out the vein. So never do a finger dissection. take off the fascia first completely like this. Yeah. So once you take off this fascia, see here, when the assistant pulls it, this is the superior pedicle. So what you actually see there is the superior pedicle. Similar way here. So what you're asking, the moment you get the superior pedicle, stay very close to the pedicle and dissect the pedicle out. The moment you dissect the pedicle, immediately what you see is the superior branch of the external laryngeal nerve. See there? See how it's seen? Focus பண்ண முடியுமா? See, that's the superior branch of the external laryngeal nerve. It's entering into the larynx. This is very important. So you stay as close as possible to the pedicle and do the dissection. 1 second, doctor. Yeah, hold it like that. See that? That's the superior branch. See, that's the superior branch of the external laryngeal nerve. Can you focus it? Able to see? No, I think you're not able to see it. I think it's very well seen here. See, that's a nerve. So what I'll do is I'll cut the pedicle and show the nerve. Yeah, hold it up like that. Same way. So the moment you identify the pedicle, go as close as possible to the lobe. Yeah. Yeah, sure. You tell me how it is. Yeah, I'll wait. That's yeah. See, that's the pedicle over here. Can you see it? No. It's very nicely seen here. See, that's the pedicle. Yeah, that's the pedicle. You can see it. You zoom in. Yeah. So that's the pedicle here. So same way, you go to the pedicle. Yeah, sutures. Sorry, I will like it. Come. Similarly, we'll do the same way. One is sufficient. So ligate the pedicle and give a gentle traction. It's very easy for us to ligate the upper pole also, upper pedicle. Yeah, give a traction. No, don't cut it, just hold it. Cut it on top and hold it. No, just hold it with a straight artery. Yeah, clamp it. Yeah, now you cut it. So it gives a traction so that they'll be able to see it. Yeah, cut it here. Great. Yeah. So next is you go here. Feed this. No, this is sufficient. Cadaver done, that's sufficient. Yeah, go all the way. This is what I said. Go, make sure you pull it as high as possible without ligating the nerve. See, that's the superior laryngeal nerve. Don't ligate the nerve. Go as high as possible under vision. Yeah. See, like that, you have to tie it. Yeah, now you cut both. Yeah, good. Cut this also. You can cut in between. So I'm cutting it here. Good. 1 second, doctor. In case you're not able to see the nerve, maybe after dissection, if you come here, I'll show both the superior thyroid, superior laryngeal vessels. So now we have the pedicle, Alice. Yeah. the thyroid is out of its bed. So on the left side, generally, the nerve is in the tracheoesophageal groove, whereas on the right side, the nerve is more in an oblique pattern, whereas on the left side is exactly in the tracheoesophageal groove. So what we have to do is now that the thyroid is out of the bed, gently go very close to the fascia and dissect it. Yeah. Again, same steps. Identify the inferior thyroid artery. See, that's it. Artery. See, you are talking about the middle thyroid vein, right? See, that's the middle thyroid vein. It's seen on this side over here. That's the middle thyroid, whereas it wasn't present on the other side. So it is present in only about 30% of the population. That's the middle thyroid vein. Now, as you go, the most important, get the inferior thyroid artery. See, that's the inferior thyroid artery. You want to see? That's the inferior thyroid artery over here. So once you find the inferior thyroid artery, go as close as possible to the capsule of the gland. This is the inferior parathyroid in this space along with the fat. So the whole thing should be dropped down. Yeah, can you feed the sutures? Yeah. So the inferior thyroid is now ligated. Yeah, cut please. So once the inferior thyroid ligated, I'm cutting the inferior thyroid at the entry point over here. Now the gland is completely devascularized over here. Once you get that point, what we have to do is, as I said, it is exactly in the tracheoesophageal groove. So this is the trachea. That's the esophagus. See, that's a nerve. So this is a constant landmark. You will never miss the nerve there. So cut the inferior thyroid artery, push the thyroid medially. You get the trachea, get the esophagus in the groove. Just 2-3 strokes, you'll find the nerve. See, that's a nerve. Can you see? Yeah. See, very nicely seen. Yeah. Yeah, sure. Sure. I told them before it's okay. Yeah, can you hold it here? Yeah, so I'll show the inferior, see, that's the inferior artery along with the parathyroid over here down, and that's the recurrent laryngeal nerve. Can you see now? See, that's the recurrent laryngeal nerve. Very nicely seen here, see? See, that's a nerve. Same step, once you get the nerve, stay as close as possible to the capsule of the gland, stay above the nerve, and gently dissect it. See, put a forceps, open up, dissect it. There will not be much bleeding here, even in a live patient, because this is a very avascular area. Slowly dissect it out. You have to make sure the nerve is always under vision. See, on the right side, we found the zuccocanal tubercle, whereas on the left side, there is no zuccocanal tubercle. So you cannot always use it as a landmark. Other landmarks has to be followed, like the triangle over here. So that's the nerve. So once you identify the nerve, go along the upper pole, dissect it off gently. See, Now you can actually see the entry point of the nerve. See, that's the entry point. The cricothyroid muscle, the entry point. So don't dissect any tissue unless you find the entry point. Generally, near the entry point, you'll find an artery which bleeds. You should be able to see, that's it. See, this is the artery. This artery generally bleeds near the nerve on the nerve itself. So make sure in live patient, whenever you see this, either ligate it or put a clip. Don't buzz it because you'll end up buzzing straight on the nerve. So always hold it and ligate it off. That's the entry point. So once you get the entry point, she's retracting it there. What is holding the gland is only the Berry's ligament. So gently hold it. Yeah, so I'll hold it here. Gently hold it and cut the Berry's ligament. Once you cut the Berry's ligament, you're straight on the trachea. See, that's a trachea. So cut it all around. See, by good traction, the whole specimen actually comes out by gentle dissection. See. Now you can actually see the string here. See, that's the nerve. See, this is what I was telling. Do you find the two branches for the nerve? So the recurrent lunging nerve is not always a single branch. You will find a plexus. See, this is the main recurrent lunging nerve. This is the esophageal branch over here. Sorry. Yeah. See. So this is the main recurrent lunging nerve. This is the esophageal branch. So always keep it in mind. Don't see the nerve and dissect off everything. Make sure the other branches are also seen. Try and preserve the nerve because we have had some bad experience in the past where we identify the nerve, preserve it, but still the patient has got mild hoarseness. That's because one of the small branches would have been damaged. Of course, the voice will get back to normal, but that's not a good situation. So try and identify this completely. See, there are two branches here. 1, 2. Once this is completely identified, then you can dissect it off with a cautery itself. That will not cause much damage. So over here, gently cut it. Cut it. We already removed the isthmus, so it's come out over here. So this is how it's done. You should not leave behind any thyroid tissue onto the trachea. So what you actually see is a part of the muscle, that's okay, but there should not be any thyroid tissue onto the trachea. Yeah, you have one more retractor, that one. Yeah, so you see now, this is typical total thyroidectomy. Yeah, more or less everything has been identified. So you should bare the trachea and make sure you don't take off this tracheal fascia because the vascular trachea will go off. Try and preserve this, but only the Berry's ligament gently should cut it and take it off. This is how it's done. I think.
It's a very nice dissection, sir.
No, yes, sir.
Audience, any questions, please? You can feel
Sure.
free to ask. Sir has nicely, beautifully demonstrated the nerve, the branches of recurrent. Usually we identify the one nerve we trace, but one more branch is nicely demonstrated. So any questions, audience, please feel free.
You can always come back and see here because everything is seen much better here also. The cricothyroid muscle, all the muscles, both the nerves, the superior laryngeal, recurrent laryngeal, parathyroid, everything is seen here. You can come and see it here later. Any questions?
Questions, please. Any clarifications, please?
Sorry. One more point I would just like to add is in case you injure the parathyroid, always make sure you auto transplant the parathyroid. Even though there are 3 parathyroids which is preserved, even if one gets injured, treat it as a single parathyroid only and then auto transplant it. That's very important and get it into a habit, especially when you're doing central compartment neck dissection.
Sir, during the dissection, my one more, sir. During the adherence of the gland over the isthmus zone or tracheal zone, how you used to dissect, sir, from the tracheal? You used to prefer the dissection by the method or use any other method to for the adherent case of gland?
If the gland is
Yes,
adherent to the
yes.
trachea,
Yes, sir. Trachea or a tracheoesophageal groove. Sometimes it gives identification nerve is very, very difficult.
correct.
So that situation, how you overcome that situation? Sir?
Correct. So of course, in many patients, we have actually faced a situation. Generally, if the gland is adherent, then it is going to be malignant. So very high chance that they will require iodine therapy. So if the nerve is functioning pre-operatively, I think you should not injure the nerve at all. So you should take every effort to try and preserve the nerve. You may leave a little bit of tissue onto the nerve and dissect off the lobe. In case it's adherent to the trachea, still you can leave behind a little bit of tumor tissue and take it off without injuring the trachea. The reason is that radioiodine therapy works extremely well for well-differentiated thyroid carcinomas like papillary carcinoma. In case the nerve is paralyzed preoperatively, then you can identify the opposite side, completely preserve it, and dissect off this tumor along with the nerve itself. So that's the way we dissect it, sir.
Thank you, sir. Any role of nerve stimulators? Sir? Stimulators, they're now using the nerve stimulator.
Yeah.
Allow any role in such a situations we have used it in this?
Correct. So recently we just had a discussion about this. Generally, we have not been using nerve stimulator until last year. Only for the last 6 months, we're using nerve stimulator for two reasons. One is medical legal issues. So we always use a stimulator, not to identify the nerve, but post-operatively, we check the nerve function and we give a slip printout to the patient. That's one point, sir. The second is the nerve stimulator, more than identifying the nerve, it is useful to check the velocity of conduction of the stimuli along the nerve. In case you find a very hard lobe, you're dissecting the nerve, you've little bit injured the nerve, you stimulate the nerve. So you stimulate the nerve preoperatively, and if the velocity of the nerve increases by 2 times, 3 times, that means there's a very high chance you injure the nerve. You can avoid completion on the other side and try and stage it. Maybe after 3 months, do the completion on the other side. So in that point, the nerve stimulator is extremely useful, sir.
Thank you, sir. Thank you very much. Nice demonstration. This is a very great treat to watch. If
Thank
you
you.
permits, we can give the time for them to start their own participants. Sir, if
Sure,
you finish up another 5 to 10 minutes, we
Sure.
can give participants.
Thank you, sir.
So,
Thank you.
now,
Thank you.
now participants can respect to table. We can start your dissections as per steps. You can start.
Correct. I got used to this because there was a time when I used to do a little bit of microvascular surgery, so I got used to this. But there are a lot of people who do it without this. They're very comfortable. It gives you at least 2.5 times magnification. Yeah. No, microscope is very cumbersome. To move the microscope, see, this camera itself was very tough to move. Microscope is even tougher. So best is a loop.
Your kind attention, please. Sir, thank you so much. It was a great academic session where we learned valuable tips on thyroidectomy. I now request Professor Vijay Sundaram S to felicitate the speaker with the memento. Thank you, sir. I now request Emeritus Professor Dr. Ratnaswamy, ACS Medical College, Chennai, to felicitate the chairperson, Professor Vijay Sundaram, for chairing this session. Thank you, sir. The participants can go ahead with the dissection. If you require any assistance, please ask the resource person.